Rehabilitation Sciences YouTube channel. And today we are here with the skin, the great forgotten in treatments and entry key for application of any techniques. And we are privileged to have with us Stefan. So Stefan, we would like to have your consent for making your lecture live on YouTube, sir. Mr. Stefan, we would like to have your consent for making your lecture live.
Yes.
Yeah, thank you. Thank you for giving your consent. And moderator today, Dr. Sagun Agarwal, he'll formally introduce our faculty today and start session.
Good evening, everybody. For today's lecture, we are having privilege to have Stefan Richelli with us. He is a physiotherapist and osteopath. He is the creator of Richelli facial quadrant system method. He is the creator of Richel's manual therapy tools. He is professor of Masters of Instrumental Therapies of UCJC University. He has got more than 12 years of the clinical experience. He is having his own clinic in Spain. We welcome you, Stefan, or Rehabilitation Science Group. Thank you for sparing time for your this lecture. Thank you, Stefan. You can proceed.
Okay, thank you so much for the Rehabilitation Science Group to invite me to give you this speak. This speak is, well, it's about the skin. I think it's the great forgotten in therapy, because normally we try to reach tissues which are under the skin and forget that the skin is, well, all in the body. When we are talking about skin, it's not only a barrier that protects us from the outside, it's also the biggest sensitive organ, and it has a big implication in mobility. And we will see how important is the skin for me in manual therapy or in any kind of therapy you will apply, because the skin is the first step you have to go through to reach the rest of the structures. So let's see what has happened with the skin. Okay, in the traditional fascia system, and just to have a brief record of what is fascia. Fascia wraps everything in the body. Everything is involved in fascia. Everything is connected by fascia in the body. So for me, the fascia system is the most important system in the body, because everything is connected and has a direct inflation with the fascia. So we can say we are muscular therapists or we are neurological therapists. Every time we have any kind of intervention in the body, we are having a direct action about the fascia system. And if we don't understand the fascia system, how it works and how it is, the compensation it's made, we are not working well in our therapies, and maybe don't have the effects that we really wanted. The traditional fascia system consists about skin interconnected with the superficial fascia and deep fascia, and this connected with the muscle, and they give normally specific or more importance to the superficial fascia and deep fascia. But for me, the skin, as I said, is the most important fascia level for me, and I will explain it why. When we said that fascia is involving or wrapping all the body, and maybe the fascia structure, this is no doubt this is wrapping all the body, is the skin. So we can see it everywhere. We see that snow breaking point inside the skin that separates some skin from other skin. It's all one suit that we are wearing the whole day, the whole life. So it will be important, the changes that suffer the skin. When we see the skin, we will see that the skin is connected by a retinaculum, these are collagen fibers, to the superficial fascia, and the superficial fascia to the deep fascia to the muscle, to the epimysium, perimysium, and everything is connected through the fascia systems still to the bone. And the last picture we see here, we go from the skin still to the bone, everything is interconnected by fascia. So the difference of movements in superficial and in the lower levels were very important. This retinaculum were specific to separate the movements on deep side to the lower or higher part. And depending of the orientation of these collagen fibers, the mobility of the different levels will be different. Normally, in normal condition, the skin, they told that the retinaculum are straight. and allows movements in all directions. So the skin has the same mobility in all directions. And the superficial fascia with the deep fascia have the retinaculums, which are orientated specifically in the way that the muscles move. So this is the ideal point. Normally we have alteration, or if we have some dysfunction of the skin and the mobility of the skin, this retinaculum will not straight, maybe will be in another orientation, or will be more stiff, because there are a lot of retinaculum, especially when there are a lot of compression, like in the hand surface, or when we're carrying it back for a long time in some place of the body, there will be a reinforce of this retinaculum and giving less mobility in the skin in this area. So what is inside the skin, or what is inside the superficial fascia and in the skin? We told it's a sensitive organ. Well, skin is full of receptors of compression, of strange sensibility, and this will have a direct influence of the muscle tonus, because if there is too much tension in the skin in the superficial fascia, that will makes the muscle contracted. And if there is a less tension or compression, and the sensor has no activity, the muscle is too much relaxed and don't have force. So the way to, well, when we have a strong muscle, we say we have to relax it, and when we have a relaxed or too much relaxed or low tension in the muscle, we say we have to enhance the muscle. But this is not the way. We really have to release the tension or modify the tension of the sensors to have an optimal muscle tonus. If we analyze the skin, we will see that we have the same system, or like in the fascia system, we have the epidermis, dermis, and hypodermis, and all is connected by collagen fibers. So depending on which orientation we have in the skin, or if we have more or less collagen fibers inside the skin will be more mobility or less mobile. So if we have low mobility in the skin, and the skin is connected with the superficial fascia and the deep fascia, we will understand that less mobility of the skin will have a direct influence of the mobility in lower levels. And why? Think about that when we are moving, or when we have a deformation of our body, the most deformity or most mobility will be in the surface, because if we stretch something, or like we bang one joint, here we have a lot of tension, and inside we have compression. So the most tension in the superficial is only possible if the skin can move free. If there's a restriction of movement in the superficial, this makes a restriction of mobility. And this is why skin is so important in the mobility of the body. We have, let's see. Okay, skin adapted to its needs. So it will be different, or the skin adapted to the volume and the necessaries of the body. So if we have a very big person, all the skin must be, he will have more skin than a very thin person. And also a person who's the whole day sitting and having a convex formation, or well, is short in the front side and long on the back side because he's sitting, the skin will adapt his longitudinity or his elasticity, and will be less mobile in the front side and more mobile in the back side to compensate just the movement. So it is also seen that a big person, or person who have a lot of skin, are more flexible, especially when they have a lot of fat inside. That gives more independence of contact between the different fascia levels, especially with the superficial fascia, and that allows that the skin can move more free and make compensation of elasticity in the body, and allow so move better. In comparison, it's like if we're drying or have a suit on, a very slim suit on, we can move well. And when we have sport clothes on that are very wide, we can move quite better. So we have to think that the skin is like a suit, and if we don't have the right suit on, we can move well. So that's why skin is one of the reasons it's so important, and in combination with all the sensitive nerves that giving information to the muscle and change the muscle tonus, making it more strong or less strong. Charlotte Paul, is one surgeon that has discovered specific tension lines in the skin. And these tension lines, he has discovered it with measuring with a special device that gives an input that makes a wave, and then they have two other sensors that looks in which direction goes this wave. As stiffer the skin is, or the tissue, it moves the wave much faster, so we can exactly know in which direction moves the wave or the tension inside the skin. And he has discovered that especially on the trunk, these tension lines of the skins are horizontal, and in the legs and extremities especially, they are vertical. This has an explication of when you analyze what kind of movement you have in each part of the body. The trunk has rotation and flexor extension. So if you have these levels, you can make a torsion between each tension line, and you also can make flexor extension separating them like an accordion. That allows quite a big mobility in the skin. On the arms and legs, well, in the extremities, you have long strikes, long tension lines. Normally, the movement in rotation is not so important than the flexor extension, and you have to limit it, this extension. For me, in this part, the skin will be like a ligament. If it's short enough, it will have a restriction of movement, and like it's a protection. When it's overstretched, the sensor will be activated, the muscle contracts and stop the movement. So it's in relationship between skin and muscle contraction also. And it's very important to know which direction are these tension lines, because if these tension lines are too strong, they activate it too much the muscle, and if they too less, they can deactivate the muscle. So very important when we treated the muscle which is below, or the tissues that are below, that we respect these tension lines, and then we remember in which direction we go to release or increase the mobility of the skin in specific areas. So very important to know. And remember that the orientation of the collagen fibers are also depending. Well, this is the natural situation, but this can change a little bit in a specific sport activity that needs more concentration of fibers or direction in one specific area. Or a person who's all the day sitting and doing nothing, maybe this is, orientation is, it's like a chaos. Each goes in one direction because there's no stimulation of these fibers to having good orientation. So this is the optimal condition, and they will have changes in sport activities or not activities. When I'm talking about sport, I can also say any kind of work that you are doing. So very important, the skin tension lines, because in surgery, they use them to make a specific, when they cut the skin to go inside the body, they follow these tension lines, because if they go through them, the scare will be under tension and will make a good scare. If they're on the same tension line, the tissue don't separate so much, and it's easier to have a good scare. And if we follow this idea that the surgery use the specific way to make the incision in the skin, we don't have to forget these tension lines. But if there is another tension, because it's a restriction of skin mobility in one specific area, and the skin, we have only one, is all interconnected, maybe one tension in the hip, while you have an injury or something like that years ago in this area, can make a direct tension in the higher part, and changing a little bit this tension lines where you make the incision, or when you will make in any kind of treatment. So very important the relationship of all the skin in all the body, because we are wrapped by the skin in all the body, and one tension in one part in our suits can change the mobility in another one, especially when we're wearing, well, if you lift the arm and we stretch a little bit our suits, we will see that we have a restriction of movement. So any kind of tension can restrict the movement of our body. Okay. So when we are studying the anatomy of fascia system and studying the relationship between skin and superficial fascia and deep fascia, I especially follow Carla Stecco, which is an Italian anatomical professor that she studied a lot of fascia. And she discovered, well, and other authors also, that there are specific areas where the skin is more fixed on the body to the deeper layers. So we have greater fascial adherence, GFA. All these black lines are where the skin are more fixed to deeper layers. This is very important because these lines where or these areas where the skin are more fixed separate our body in quadrants that have a specific function. In all this area, we have a muscle that makes a specific movement of the hip. Here we have also specific muscle that make a flexion. So each area is in a specific area for a specific movement. And the combination of different areas of quadrants allows a complex movement. But what happens if we have too much adheration of the skin and the skin with superficial fascia and deep fascia? Then we have a breaking line that don't allow some compensation, and the unit or that all these units of quadrants works together. And this gives normally the problem. Specific, this area are where superficial bones like the ribs, the hip, but also on other anatomic parts like the alba line and other parts which are not so with superficial bones. Also the joints are very glued, the skin with the fascias. Then between the different quadrant systems or quadrants elements, where more than 3 quadrants conflude, we call them anatomical breaking points. There's where more stiffness also or more tension reach, because we have to work together with all the section, and there where they conflude and where are more restricted the skin to the deepest layer, we will have more adheration to the deepest layer. So the first step or one kind of adheration will be the greater fascia adheration, and a stiffer or more adheration will be on anatomical breaking points. And casual, all these points, if we compare them, there will be also many myofascial trigger points. And also when we're talking about fibromyalgic points, we will discover that they have a lot of influence, or will be practically the same points that in myofascial research. And then we can have in the specific alteration of the fascia or skin tissue, because we have an injury or we have an alteration because we're making a specific movement too much time, or we are not moving the tissue, so we can have a restriction in a specific area. So if we have in a specific movement in one area that has to work well with the areas that is close to him, and we have one area that don't move well, so we have an alteration of the function on all these parts, and then maybe we will have a problem in a very separated part. And this is what we have to find out. How we can consider or say that the skin is too much fixed to the lowest level, or where we have too much adheration. Well, we can find out this problem with 2 ways. We can use a cup, that the ones that we use for cupping techniques. And what happened when we put the cup and make it under pressure? Normally the skin goes inside, and so we have fixed the skin. We can separate it from lower levels. So if we push the cup up without separating it from the skin, the lower levels will go also up. If we don't have no kind of deformation of the skin and the skin don't move up, then we can say, okay, there's a big aberration that don't allow quite mobility in the lower levels, because it's too much fixed, especially if we compare it with parallel areas. So if you make it on one breast and then we make it on the other, and we have more stiffness, or don't can separate the skin on one side of the breast and better on the other side. So we can consider that in one specific area we have too much restriction. If it's both sides the same, where we can consider that's maybe equal and not a big problem, but normally we have to be able to separate the skin a little bit from each area of the body. This will be the best or the optimal condition. If we don't have a cup, you can pinch the skin also with our fingers. So we have to see if we are able to pinch the skin with the fingers, how much tissue we can put between our fingers, and how much we can separate the skin from the lower levels of tissue. And this will indicate us how much mobility has the skin in one specific area. Once we have find or think that in specific area there's the problem. Okay, how we can, or what we have to do different when we start to treating the patient. Normally, when we have a muscle problem, well, we make a massage, make maybe long strikes. When we have a problem on the quadriceps and a knee problem, we make the strikes in a higher position from the knee to the hip. This is normally what we do to allow also the blood flow go in the right direction. But how I told you, for me, it's not so much important to treat the muscle. My objective is not to treat the muscle. My objective is to release the tension of this muscle, because normally when I have a knee problem, I have too much tension or too much muscle tone in the quadriceps. And now again, we're going to imagine that we are wearing trousers, we are wearing clothes, and we're going to sit in a chair, and we feel that our trousers are too slim and that we have too much tension. To the knee, from the hip to the knee, and from the back side of the knee to the front side, to have more
Stefan, I'm sorry to interrupt, but the audio is not very clear.
Dear participants, Stefan would be joining soon. There is the internet problem is there. Just wait for a few seconds.
Sorry, my system broke down. Let's go.
No problem, Stefan. No problem.
Okay, we go again. We are here.
Yeah, from here.
Okay, perfect. So to release the tension, how I said, we push the tissue down in direction of where the patient feels more tension. From the higher part to the lower part, and from the lower to the higher part in this direction. So to release the tension. What happens in the opposite side? If we feel too much pain when we make an flexion in the backside of the knee, we have a problem of compression. So there's too much tissue in this area. So to relieve the compression, we have to push the tissue from the center of the joint in the opposite position and to the front position. The same, but in the opposite direction. The only thing that is the same, that we have to go from back side to front side because too much tissue in this area. To understand this is very easy if we're looking at a joint, but what happens if we're treating on the trunk? It doesn't matter is this the hip or is this in the middle of the dorsal area. Just there where you have the flexion or the convex area, we have a lot of stiffness or tension in one specific area. And the patient says, okay, I feel my tension in this area or here where I have marked with this point. So we thought that in the convex area, in the superficial, there's too much tension. So we have to release this tension in this specific area where you feel too much stiffness. So we have to push the tissue from all directions just to the center of the point where you feel the stiffness or the tension. Specific or more straight, we have to treat the tissue just in the direction where we feel most restriction of the movement of the skin. So we can put the hand on the skin, move the skin just to the center from all these different directions, and we will feel in which direction it's easier to push the skin to the center. And just there where we find or feel there's more restriction to move the skin to this point, there's where we have to work more intensive to release the less of mobility of this area. And the same will happen if we have an extension, we have a compression of this the tissue, and we feel some pain in this area. Well, exactly in this area, that can be also a joint problem. But if we have eliminated that is not a joint problem, maybe we have a compression of soft tissue, and this will make the pain, like a trigger point or something else. And so again, we have to remove the skin and the superficial tissues from this area to decrease the compression of the skin in the tissues in this area. So we are moving far away from this point of the tissue to restore the elasticity of the tissues and reset the sensors that are inside in this area. So this way we have all these areas, the fascial quadrant, where I told you before, these are all specific areas where we have a specific movement or they have a specific action. But all these have to work together to make a complex movement. So we are not robots or machines that moves only in one side and then they don't have interconnection. So it's very important that all the skin can move properly, free in all directions, because as soon we have a deformation in one part, all the skin will be or must go in this direction to give more skin to allow a specific movement. And in this picture, I have showed or illustrated the direction of the strokes or manipulation of the skin we have to do. It doesn't matter if we make a manual therapy, an instrumented therapy, or using any kind of physical action, that all day must, or I think so, that we have to go in a specific way to release the tension of the tissues to allow more and better mobility. This is what illustrated this picture. So we have a specific area, we have a restriction that makes a problem. But this will be all very nice, but how we know where we have to start our intervention or where we have to start our treatment? Because now we understand that skin and superficial fascia are all connected, that we have specific area where they have less mobility and that can have an influence of the whole mobility. But if we have a pain or an injury in some part of the body, how we can know which part is the first step or the first intervention that we have to do? Normally it's not there where we have the pain. Normally it's far away. And how we can see where's the problem? Well, I put this, imagine a very strange position, but to make it very easy to understand how can have an influence the different fascia quadrants systems in the mobility of the patient, and how to analyze the body of the patient. So imagine that we have a restriction in the quadriceps. Well, maybe someone hit us, we have an hematome, there's an ulceration, and then makes less mobility of the skin, and more tension that activates the muscles, is more stiffer, and that's don't allow it in where knee flexion, and we have a restriction mobility of all these tissues in the quadriceps. And specifically, we told you in superficial, as more in superficial is more deformation in the body. And normally when we have a tension in the higher part, we have a compression in the deepest part. So it's most important to have good mobility in the superficial than in the lower levels. So imagine that we want to be in this position. So you can imagine that the skin and the superficial fascia and the lower tissues, not so much, but in the superficial especially, they will make tension on the hip that will rotate the abdominal muscular transverse rectus muscles, higher abdominal muscles, serratus, all this, and pectoral muscles, and all this fascia system. All they have to go in this direction to give more skin or tissue to allow us to compensate the less mobility of this area. So you understand, imagine this is a suit you're wearing, and you stretch a little bit the trousers in this direction, and everything is connected, but all the tissue will be going in this direction. In this direction. I hope you see my mouse moving about the body. So if you see it, that the quadriceps will stretch the transverse muscle, the rectus abdominal, the serratus muscles, the pectoral muscles. You can understand if everything is stretched in the direction of the quadriceps, maybe I can put my arm in back position and I feel pain on my deltoides and have maybe an irritation of the long tendon of the biceps. But if I have pain there and I do this position every day because I'm a dancer and I'm working on a company, my problem is not on my shoulder. And I can treat the pectoral muscle, I can treat the serratus muscle, I can treat my arm muscle, and I will feel better, but the problem is not solved. I still have the problem here, and after time, this will go again in this position, and I will have again a problem because I am not symmetric. I have one tissue that don't allow us move properly all the rest of tissue. So that's what I call the asymmetry in fascia system, or tension, asymmetry, tension and fascia system. Because if we are all restricted, we have less mobility, but this is not so much problem. But if we have specific in one area, higher asymmetry or more restriction, this will cause more problem than if we have it in all the body. So even a very flexible person that has only one restricted area here can have or can be the matter of the shoulder problem. So how we can know that here's a problem that don't let move all the body? Because normally the restricted area is not a painful area. The patient don't come and say, oh, I have a problem on my quadriceps that makes me a shoulder problem. So if you know it, maybe he can treat himself. No, you don't need a physical therapist. So how we can know exactly where the problem? There's again why I make this quadrant system, because it makes it very easy to understand where the problem. So how I analyze the body. First step, you have an optical analysis of the body. You see in this position, as you see like this, as he is like this, if he is in this position, this can give you information where is more or less tension in the body. But for me, it's very important to analyze the movement of the body. And we thought that even a restriction on the ankle can make a shoulder problem or neck problem. So we have to analyze the whole body. It doesn't make sense if you have a shoulder problem only to analyze his shoulder and not maybe his knee or his foot. So first at all, optical inspection. Then we make movements in standing position. Then we make movement in sitting position. And then we make movements in lying position. Why we make it in 3 different positions? Because when we stand, we have an influence of our legs. The tension of the legs have a direct influence on the trunk and in the arms. When we are sitting, they are normally in flexion. We have less tension from the lower extremities. So we can consider that maybe the tension comes from the middle or from another part. And when we are lying, we are not or where we allow that the body goes in a neutral position, and if he is still in a flex position, so we can consider that it's a problem that comes from very far or from a very long time ago, because it don't change when he's lying. And also we see the feet is if they fall right or left, on which position they are. So it's very important, all its position, and make different movements in this position. And for what we make these movements in this different position, and let's see why it don't work this. Okay, I hope I can go back. No, bad. Okay, I will see how I come back again. Okay, to know exactly which is the area or the quadrant that we have to work on, we told we make inspection or movements in standing position and dynamic or dynamic and standing and sitting and lying. We make different tests, and we will feel for each specific test, we will feel specific restriction or tension in one specific area. While we are making so much tests and different movements, but what is curious that if we have really a restriction in one part, and if it's very, very important restricted area, we will find that we find the same restriction making different movements in the same place. So I have put different colors, and each time if you have the same colors for different, or well, same restriction in the same area for different movements, you can be quite sure that you have a problem, or the biggest problem is here. So if you make all this movement, you have 1, 2, 3, 4, 5 same restriction or tension in one area, and you only have for all the rest, for quadriceps, you only have 2. So you can be quite sure that your problem is on the lumbar part specific. So you have to treat there at first. And let me see if I can go back. I don't know. Let me see. Back. Yeah, okay. So here you have discovered which area you have to treat, making all this examination. So you have your start point. Once you have your start point, the most restricted area, or the area that makes the biggest alteration of elasticity of movement in the body, you also know it in which position you have this problem, because we told, I see it again here at the beginning, the skin and all the tissues have collagen, and the collagen fibers have different orientation depending on the movement and the position. So many of these collagen fibers can be relaxed in one position and then stretched in another position. So we have to treat them when they are under tension, not when they are relaxed, because if they are not under tension, we don't have an influence about or we can produce changes in its configuration and inside the tissue. So once we have determined which is the area, we know also in which position he feels more stiffness or more restriction, not in where he feels his pain. There where we have found out there's more restriction in his mobility. And this also gives us later the idea in which position and which kind of exercises he has to do to make better his mobility in this area. So how can we be sure that it's really the most important area that we have to treat? So we treat this point that we have found, or this area, about 2 minutes, not more, because in 2 minutes, normally if you make a good technique, there will be a change or something that you can measure or consider, and you make a re-exploration. So the stiffness in the area you have found, your starting point, have to be quite better. In 2 minutes, normally it's time enough to have an important change that shows you that you are on the right point. So if it has a big change, you really know, okay, there's the biggest point. And also if you have a shoulder problem and you started treating his hip or his leg and his shoulder after this, it don't hurt so much, you are quite sure that the problem comes from here. So how much time you have to treat this area? As much it goes better. This means You make an intervention, 2 minutes, make a re-aspiration, treat, okay, he feels better. Okay, you go on 2 or 3 minutes more, make again examination. Oh, it's quite better. Again, 3 minutes, then re-exploration. Then he says, oh, the same as before, or it's just a little bit bad. Okay, then we have to stop. This is the time that we have to treat this point. But what happens if we make a re-exploration and nothing changed? Then we are quite sure that we are not on the right point, and we have to examine again our patient, or think about if we don't make a mistake here. If he only a little bit better, maybe, okay, if his problem is on the hip, and the hip making compensation of the dorsal and the trapezius and then the shoulder, maybe we find a tension in the middle of the thoracic area on the back side. That will increase the mobility of the shoulder, but this is not the most restricted area. And also, if we have a big release or nothing of tension in the first point that we treated, and after we have a less, or we are quite better in the shoulder, but there's still a problem, we have to see all the points that are in the middle of this way to the shoulder that maybe also can have an influence. And after treating this point, we check again the shoulder, and only at the end, when we have released all the tension of all the points that we think that are important in the movement of the shoulder, if there's still a problem on the shoulder or pain in the shoulder, then we can treat the shoulder, but not before, because if we treat before the shoulder, we don't know which influence can have all these other points. This is very, very, very important. So here with examination, we know the starting point, we know the treating position, and treating position, and also the movement, because the movement is very important during the treatment, because in a complex movement, there will be fibers that are in specific area, more tension, less tension. And if you move the patient during the treatment, you will be quite sure that all the fibers that are involved in the pathology will be treated. If you maintain a good position where you feel this stiffness or tension, but you don't move your patient during the treatment, maybe you're not treating all the fibers which are involved. So movement has to be a part of your therapy during the application of any kind of technique, ever when it's possible. And then use this mobility or these movements to show the best exercises to your patient. So to resume everything, we have the skin, which wrap it all our body. The skin is more fixed on specific areas to the layer underlying tissues like superficial fascia, deep fascia. And also, well, all these black lines indicate where it's more fixed. This determines different areas, which I have painted in different colors, which I call the quadrant system. And each quadrant has a specific function with its muscle, with its fascias, and all them together have to move properly well to allow a complex mobility, allowing to compensate the tension in all the areas and to give tissue to a specific area that has to move. So if there's a restriction on the areas where it's more fixed on deepest levels, or where's a confluence of different tensions, if we have the problem, we have a problem in the whole system, and that don't allow the compensation and makes then the problem of mobility and injury or some problem will appear. And we have to treat and find out which is exactly the point that makes breaking or don't allow us to move the body properly. And only after treating this area, we have to see which influence it has at the injury or the pain. And only after treating all the tension that has an influence on your the problem for what comes the patient, only then we can treat the area of the pain or the problem of the patient. This is very important, because the actual or the traditional way of treating a patient is, well, I have a shoulder problem, well, I look for the neck, I look for the breast, I look for the trapezius, I look for the arm, but why I don't have to look at the rest of the body? This is maybe one reason that we don't have normally in our treatments. And also to understand that the skin is wrapping all the body, and if there's a dysfunction of the skin, it don't allow us to move while it's connected to the deepest layers, all this compensation in all direction, and we have to treat our body through the skin. So if we don't know in which direction, we have to move the tissue, and under what kind of tension is the skin, we are not using the right direction or the best direction to transfer all the energy to the body in the best way. So I hope you understand. My English is not so good, sorry for it. And if you have any doubts, don't, well, I let you hear my WhatsApp number, also my email. And if you have any doubt about my explanation, please contact me, and I will, it would be a pleasure for me to explain you any doubt you have. So thank you so much. And I go back to our Rehabilitation Science group.
Thank you, Stefan. We are obliged on behalf of all the listeners of Rehabilitation Science Group for today's presentation and a very well illustrated demonstration of the important role of the skin and the fascia in movement dysfunctions and even in normal functions. Stefan, although everything was so clear, but still there were a few queries, like people wanted to know about
Yes.
the difference between the kinetic chain model of the facial system and the quadrant system of the fascia. So
Yes.
what are the broad differences in the two models?
Normally the change model is more in muscle model. They, when you see the pictures of the change model, you see different muscles which are connected and then make a change. So it's the muscle which is fascia. They considered that this is the way that of transmission. And it's for me, it's a good model when you are trying to explain the movement. When you make a muscle contraction, in which direction or which muscle has to go in which direction to make this movement. This is one point, but this is in the deep layers. But where's the restriction of this? This is more in the superficial. The muscle is more in transmission of force, and maybe the skin in the superficial fascia was more a restriction of this change. So once we have what causes the movement and what causes the restriction. This is a different concept. And I think the change model is talking more about the movement or transmission of force, and not the restriction of so much of movement. And the point that I miss in the change model is also that they really don't explain where exactly in the chain model I have to make my intervention. They speak all this chain can make in different position of the body or different kind of movement, but I really don't know in which kind of this chain I have to make my intervention, and also the interconnection of different chains, because when we're making a movement, we don't make it only in one direction or using only one change, because we are using many changes to make a complex movement. So to have the interrelationship between all the changes is also something that I miss a little bit, in which influence has a restriction in the superficial, in the transmission of the force. So for me, the change is more in the transmission concept, and my concept is more in a restriction concept.
Right. Secondly, Stefan, how individual is the fascia to human functions? Like every individual moving in their own typical way might have different patterns of facial restrictions and impairments coming from it. So, is it okay to bring people into a model system when everybody is so different?
Yeah, this is sure what you say exactly. Now let me explain. The concept of fascia quadrants allows you to have an open system. It's not restricted like a change model. Yeah? All the people that have changed like this have to this position or this other position.
Yes.
The quadrant system model allows you, independent of which kind of activity you have, of any kind of movement you have or restriction you have, it can follows different ways depending on which kind of movement you do. So in restriction and quadriceps can have a big relationship with a shoulder movement, but not in relationship with a right or left rotation. So it's an open system. You only have to find making so much movements, which is the most restricted point, and then find out which relationship it has with the pathology that the patient has. So it's an open system, it's not a closed system, and that's why it's adapted to all kind of people, people that don't make activity, a high sport performance, and any kind of patient, if he's have an injury before, or if he have any kind of illness, it doesn't matter. This systems, what is also very important, it's not depending of the therapist that make the examination. Maybe other techniques of skin listening as attention might be more depending of the sensibility of the patient. But if you have a system, an analytic system that says, okay, when you make all this movement and every time the patient feels the stiffness and not the therapist. So it's the patient that says, oh, I feel stiffness when I make this movement here. When I make the head movement, I feel it again here. And then when I move my feet, I feel it again here. It's not a therapist that makes the decision that there's a stiffness. It's the patient who is telling you where is the problem. And you only have to know after, okay, here's the problem. This tissue is connected with all this quadrant system or with all these areas which are confusing, and then can make or can explain why I can move my other shoulder.
Right. Just finally, one more question, and then we end with this. Stefan, where in the steps of treatment would you keep the facial treatment? Would it be before muscular system, or would it be after muscular system? Like, is it step one of the treatment, or it comes later?
As I told you, any kind of intervention in the body is fascia treatment. You can say I might make a muscle treatment. I can say I make a nerve treatment. Everything is fascia treatment. You can say what is more specific fascia treatment or less fascia specific, because muscle is involved or rubbed by fascia everywhere. First, how I told is to find where's the most restriction area. Then we have to find out how we treat the restricted area. If it's more in the superficial, it's more in deep. Is there more sensitivity, or there's more sensitive problem? It's too much sensitive that everything is too much painful. So we have to decrease the sensibility. Then we can go deeper, and then maybe if there's also muscle contraction, that's for a long time we have a stiffness inside the muscle. So we have to go step by step. First, release the tension, then to release the pain and allow us to go deeper in the tissue. And then we can go step by step, releasing or treating the different kinds of alteration of different levels of fascia. But fascia is everything. And if you see it, really, everything is fascia treatment.
Yes. Is your book available in English?
It's not finished right now. Well, it's finished for me. Now they making the revision of the whole book, and we started also the translation in English. And I hope that at the end of October, starting November, it will be published for all countries, and it will be available in digital way and printed way.
Okay, thank you. Thank you so much, Stefan, for being with us and sharing this wonderful piece of information today. Thank you.
Thank you so much.